interferon gamma is responsible for the granuloma. So as you could see from this, our discussion, it is the CD4 cells which will be releasing this interferon gamma and which will be having a stimulatory effect in your, macrophage. And this interferon gamma is responsible for the granuloma formation. Now moving on to the next question. Which of the following is true regarding the cystic fibrosis? Yes. So cystic fibrosis, they have asked two questions from in this exam. One is actually the mode of inheritance of cystic fibrosis, that is autosomal recessive. And regarding the what is the pathogenesis or the clinical features involved in the cystic fibrosis. So as you could see from our discussion, so what happens in the sweat duct? So in the sweat duct, normally through the CFTR channels, the chloride enters. But what happens in cystic fibrosis? This chloride channel is closed. This chloride channel is closed in cystic fibrosis. So the chloride will be remaining in the lumen of the sweat duct. The chloride will be remaining in the lumen of the sweat duct. So the sweat chloride levels will be increased in case of your cystic fibrosis. The sweat chloride levels will be increased in the case of cystic fibrosis. What happens in the other ducts? So other ducts, what happens? Normally chloride comes out of the cells into the lumen, but in cystic fibrosis, in the other secretory glands, what happens? Again, because this chloride channel is closed, chloride cannot come out. Chloride cannot come out. So the chloride in the secretions will be reduced. More chloride will be available in the epithelial cells, but in the secretions, there will be reduced chloride secretions. So here, increased chloride secretions, increased chloride levels in the sweat will be a diagnostic feature. Also, in the secretions, there will be decreased chloride levels. In the sweat, the chloride levels will be increased, whereas in the other secretions, the chloride levels will be decreased. Chloride levels will be decreased. Then, a 75-year-old female presented with a history of diabetes and hypertension and breathlessness. They would have mentioned you about a cardiac biopsy. In the myocardial biopsy, they would have given you this image. So this was the image given roughly told by you people. So in the myocardium was given, the histopathological image of the myocardium was given. And in the myocardium, you could see some deposition of pinkish material. That pinkish homogeneous material was deposited. So this was the image actually told by many of the students. So in the myocardium, deposition of this eosinophilic pinkish material usually will be giving a clue to the diagnosis of the amyloid. So the options given in this question was dilated cardiomyopathy, hypertrophic obstructive cardiomyopathy, restrictive cardiomyopathy, and atrial fibrillation. So students, if you want to change any options, you feel that this option was not given, you are feel free to give me the answers. We'll modify accordingly. So here, this amyloid deposition. So out of all this dilated, hypertrophic, or restrictive cardiomyopathy, amyloid deposition mainly causes this restrictive cardiomyopathy. Amyloid deposition mainly causes this restrictive cardiomyopathy. So as you could see from our discussion, so restrictive cardiomyopathy, there are so many causes, but amyloidosis is the most common cause of restrictive cardiomyopathy. So out of the given options, this restrictive cardiomyopathy is the option to be chosen. Then, which of the following is not a feature of Down syndrome? Which of the following is not a feature of Down syndrome? Yes, in Down syndrome, child can have hypotonia, patient can have hypothyroidism, and short stature is usually a feature of Down syndrome. But usually this Down syndrome is caudal regulation syndrome is totally a different entity. Caudal regulation syndrome is usually not seen in Down syndrome. So usually that will not come as a thing. So hypotonia, hypothyroidism, and short stature can be seen in Down syndrome. And this caudal regulation syndrome will not be usually seen in Down syndrome. So we discussed this in detail. Now, this is also one of the standard topics for your INCET, that is the CSF findings in meningitis. So they would have given you the clinical features of meningitis and the CSF findings. What was the levels told by most of the students? The given values though the exact values were not recollected by the students. So they have given that the glucose levels are normal and the lymphocyte count is increased. This is a very important clue, guys. If you see, lymphocyte count is very much increased in the CSF and the protein levels are near normal, we have to think of viral meningitis, viral meningitis. So the glucose levels are near normal, protein levels are also near normal, but lymphocytes increased, the diagnosis will be a viral meningitis. So as you could see, for glucose, it is 20. Okay. So glucose level is 20. Okay. 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 Thank you. And the protein levels are normal. So you could see from this discussion in our workbook, like the viral meningitis, lymphocytosis will be a predominant feature. Also, what you will remember in this tuberculous meningitis now, you can see pleocytosis and the chloride levels will be very low. That is a diagnostic of tuberculous meningitis. But in bacterial meningitis, what you will remember, guys, protein levels will be high and glucose levels will be very low. And also in tuberculous meningitis, you know, here cobweb formation in the CSF. So all these are important diagnostic points to differentiate between the different types of meningitis. Yes. Now this is also again a standard question. Which of the following is not a marker of seminoma testis? So this thing actually they have asked about the various markers in the seminoma testis. I'm not sure that whether this is asked like a multiple choice questions, 1, 1, 2, 1, 2, 3, 1, 2, 3, 4, 5, like that. So if you could see all these markers, OCT3, NANOG, PLAP, and KIT, all these things are positive in seminoma testis. So HCG is usually positive in choriocarcinoma and related tumors, but OCT3, NANOG, PLAP, and KIT, all the markers are positive in a seminoma testis. If any other option is you want to modify, please put it in the chat box. We'll modify that accordingly. But most of the students given this options only. So we are going by this option. So all the markers, so it is a multiple choice type of questions. All the markers are positive in seminoma testis. Okay. Okay, Ramya. So as you could see, OCT3 by 4, NANOG, CKIT, PLAP, GGT, and HCG are positive in seminoma testis. Yes. So again, this is one of the important standard questions we discussed. Ring K crystalloids are seen in. Yes, this is a very standard question and also a repeat question in your INICET exam. Ring K crystalloids are seen in your Leydig cell tumor. Ring K crystalloids are seen in your Leydig cell tumor. Yes, as you could see from our discussion, these ring K crystalloids will be these crystal-like structures which will be seen in your. Okay, okay. So if HCG was given, that will be the least option. HCG usually you will prefer only in the choriocarcinoma. Seminoma testis, HCG is not that much markedly elevated. So you want to rule out one option, HCG you can rule out. Yes, HCG you can rule out. HCG you can rule out. Nano will be present. HCG you can rule out. It is seen in usually in choriocarcinoma only. And also Leydig cell tumor, what important? Yes, it is a potential question for your NEET exam also. Leydig cell tumor, I told no, you have to remember 2L. One is lipid droplets will be seen in your Leydig cell tumor and lipofuscin pigment will be seen in your Leydig cell tumor. So it is because of this lipofuscin pigment only, this Leydig cell tumor will be having a brown cut surface, And also you'll be remembering that it is a hormone producing tumor in the testis. Yes, patient can present with if it is what androgens of that is produced in children, it can present with precocious puberty, and in adults, if estrogens are produced, then the patient can present with gynecomastia. Remember all these points we discussed during our session. Then this is a standard picture. Actually, with the same pictures, many students told that this image was given. A 45-year-old male presented with a low urine output, and histopathological examination showed the findings as seen in the image, and immunofluorescence showed no deposits. Which of the following is most likely to be seen? Yes. So as you could see, this is a patient is presenting with a low urine output, and this is the standard picture where you can see this. This is the crescent. Yes, the crescent. So you could see this crescent is compressing the glomerular tuft. Yes, this crescent is compressing the glomerular tuft. So it is because of this only this patient will be having a rapidly progressive glomerulonephritis. The renal failure will be more marked. So there will be compression of the capillary tuft. And so because, and also they have given a very important clue that there are no deposits, no deposits. So students, please remember this table column from our workbook. Type 1 RPGN, it is anti-GBM, that is a good pasture syndrome, where the antibodies will be produced both against the alveolar capillary basement membrane and the glomerular basement membrane. So patient can present with hemoptysis and hematuria, but there will be deposits will be there. There's a linear pattern will be in the immunofluorescence. Yes, you remember that. Then the type 2 RPGN, what you'll remember, immune complex, that is in the case of SLE, post-infectious streptococcal glomerulonephritis and phenolphthalein purpura, where there will be deposits will be there. So there will be a granular deposits will be there in the immunofluorescence. So both in type 1 and type 2, there will be deposits will be there. But here they have given that there are no deposits. No deposits means it is a quasi-immune type of deposits. So it is a quasi-immune, no deposits, but it is ANCA positive. So it is ANCA positive. So your vasculitis, especially this granulomatosis with polyangiitis, that is a vaginous, and microscopic polyangiitis will be giving you this type 3 RPGN. So the answer here is this is ANCA associated vascular, ANCA associated presenting glomerulonephritis, presenting glomerulonephritis. Yes. Question said that it is a, they themselves said that it is a RPGN. It is ANCA positive means directly it is ANCA associated. ANCA associated. Okay, there is Surya. Okay, Salman. A patient with the COVID-19 was treated with the high-dose steroids. Later, he presented with the nasal obstruction. The histopathological image is shown in the picture. And what is the most likely diagnosis? This is one of the practical scenario which most of you would have encountered in the clinics, that this COVID-19, when they are treated with the high-dose steroid, the immunosuppression actually predisposed to this mucormycosis. Yes. And in the histopathological image also, I think they would have given you this sort of image, which is a broad aseptate fungus and branching at 90 degree. This is nothing but your mucormycosis. Yes, you remember from our discussion, acute angle branching, septate hyphae, that is aspergillus, whereas broad fungus with branching at 90 degree, you will be thinking of mucormycosis. And also this nasal obstruction, COVID-19, steroids, all this points towards a diagnosis of your mucormycosis. So you could see from our discussion also this image. Then some of you told that there was an image, actually histopathological image they have given with this basal cell carcinoma, and they have asked you the diagnosis of this basal cell carcinoma. Yes, this similar sort of image was given. People were saying that, some students were saying that. So you can see this in this tumor, there is arrangement of this basaloid cells, nest of this basaloid cells, and you can see this, there will be a cleft, there will be an artifactual cleft between the tumor nest as well as the surrounding stroma. And also, if you could carefully see, there is a peripheral palisading of the tumor cells. There will be a peripheral palisading of the tumor cells. So these are the classical picture of your basal cell carcinoma, that is the rodent ulcer. So the diagnosis here is the basal cell carcinoma. Remember students, also what we discussed in our neoplasia, basal cells, there is no benign counterpart, only the malignant counterpart will be there. Basal cell carcinoma, other MCQ in pathology. Yes, it is the malignant tumor without metastasis. Yes, both basal cell carcinoma and the glial tumors or the malignant tumors without metastasis. That means what? They are locally invasive, but there is no metastasis. Remember that point also, that can be a potential future question in your NEET exam. Now the next question, again, this is also a standard question. So a patient presented with the bullous lesions on the skin. Patient is also having, they have given the history of the oral lesions. According to most of the students, the image given was like it is a suprabasal bulla. See this? Most of the students told that there was a row of tombstone appearance. Yes, most of the students told that. Okay, gross image. Okay. So this was like a suprabasal bulla. So suprabasal bulla, that above this basal area. So you can see the basal keratinocytes in a row of tombstone appearance. So this basal bulla, suprabasal bulla will be that giving you the diagnosis of pemphigus vulgaris, and this will be usually giving you a fishnet appearance in your immunofluorescence, fishnet appearance in the immunofluorescence. And also you can see the acantholytic cells. You can see if it is a suprabasal split, then it is a pemphigus vulgaris only. Suprabasal split, it is a pemphigus vulgaris. In bullous pemphigoid and in dermatitis herpetiformis, the split will be subepidermal. In bullous pemphigoid, the split will be between the epidermis and the dermis. If it is suprabasal, you have to think of pemphigus vulgaris only. Pemphigus vulgaris only. Oh, okay. Clinical image. Okay. Then this is one of the controversy questions. Actually, most of the students were experiencing it. So the students were saying that the question that was asked is anticoagulant used in the vacutainer used for the glucose estimation. And some people were saying that the light blue word was used. We don't know why the examiner has used this word for a light blue, but please remember the vacutainer used for glucose estimation, that all of us know that it is a gray topped vacutainer. And remember, they have not asked you about the additive. They have asked about the anticoagulant used in the vacutainer. So the anticoagulant used in the vacutainer is your potassium oxalate. In the potassium oxalate. If the question is, yes, okay. So if the question has been asked, what is the additive, then the answer could have been a sodium fluoride. But if they would have asked what is the anticoagulant used in the glucose estimation, then the answer will be potassium oxalate. So this is a gray topped vacutainer. But all of us know that light blue topped vacutainer, that is the used for your contains 3.2% sodium citrate, and that is used for your coagulation studies like estimating PT, APTT. That coagulation profile, if you want to estimate, you use this light blue topped vacutainer. So this is a controversy question, guys, but this is the actual fact. You should know this. Okay, the glucose estimation, gray topped vacutainer, anticoagulant potassium oxalate, additive sodium fluoride to inhibit enolase. Light blue, sodium citrate, coagulation profile test. This is the point you have to know. And again, you could go through this, our images given in our workbook. Again, this is a potential source, a future MCQs again. Then there was a question asked, I heard there was a question asked about the super antigens. So they were asking about, like, this is a microbiology related integrated things. And the options were cholera toxin, Clostridium, botulinum, and Streptococcus. So this question also we discussed during our test and discussion. This questions was discussed. So the super antigens, there are diseases associated or your toxic shock syndrome, diabetes, scarlet fever, staphylococcal scarlet syndrome. So there are so many things. So these super antigens here, out of these options is your Streptococcus. It is your Streptococcus. Cholera, Clostridium, botulinum will not be acting via the super antigens. It is the Streptococcus. Scarlet fever. Then I heard they were given an image of the histopathological image, and they have asked about identified the marked structure. And most of you told that they have marked about this empty white spaces. Yes, remember, bronchioles will have this epithelium. Bronchioles will have this lining epithelium. And if it is a bronchi, please remember, bronchi will have cartilage. Bronchi will have cartilage, and bronchiole will not have the cartilage. Yes. And the empty white spaces are the alveolar space. Okay, they are the alveolar space. And also you will remember the differentiation of the structural differences of these bronchioles. Yes, it is the bronchi, bronchioles, lobular bronchiole, terminal bronchiole, then respiratory bronchiole, then alveolar duct, then alveolar sac. That is how this respiratory tree branches. So empty white spaces or the alveolar spaces. Yes. So this we have discussed during our CBC lung and also in our hyaline membrane diseases, that empty white space is the alveolar space. Okay, Rajan. Then there was a question on patient underwent a surgery for adrenalectomy. Post-surgery, the patient developed pituitary adenoma and hyperpigmentation. So what is the most likely diagnosis? Yes. So this, you remember from our discussion, So Nelson syndrome, what is the Nelson syndrome? Initially, the patient would have had a Cushing syndrome, Cushing syndrome. So because of that, they would have done the adrenalectomy. Yeah, was first to initially start, there was an adrenal tumor. So they would have done that adrenalectomy. So post adrenalectomy, the pituitary will be stimulated. So there will be a large destructive pituitary adenoma. So if you do this, then this can result in this hyperpigmentation. So this is the Nelson syndrome. So everything will start with the Cushing syndrome, removal of the adrenal tumor, then pituitary stimulation, resulting in this Nelson syndrome. So the answer here is the Nelson syndrome. Nelson syndrome. Yes, very good. Okay. The terminal bronchiole and respiratory bronchiole also will not have this empty white spaces. Without epithelium, it can be there. Okay. This alveolar sac. Then this was the, I think this was the, this type of questions only actually students told me, what is the stain used in cervical smear? And this is a very basic question. Cervical smear, it is a Papa Nicolau smear. Some students were saying that image of a cell was given in the pap smear. So you know how to interpret the images. We know that the superficial cells will be having a eosinophilic cytoplasm pyknotic nucleus, and this and this intermediate cells also will be having a slight a bluish cytoplasm and folded cytoplasmic borders, cell borders. Then you have parabasal cells and basal cells, parabasal cells with the greenish cytoplasm, and basal cells will be appearing in a cluster. And basal cells will be having a very scanty cytoplasm. So you can expect a future questions that superficial cells, estrogen preponderance, proliferative phase of the menstrual cycle, and your intermediate cells, that is the progesterone based cells, and more common in the secretory phase of the menstrual cycle. Parabasal cells and basal cells is usually seen in your postmenopausal and in a state of atrophy. Yes. And this was actually the image. The following stain is used in the immunohistochemistry of HER2-neu done in breast cancer. Please remember, in immunohistochemistry, yes, other options are Addison syndrome and Conn syndrome. Okay. Okay, we will correct it accordingly. Then, which of the following stain is used in immunohistochemistry of HER2-neu done in breast cancer? Remember, in the technique of immunohistochemistry, you want to identify the antigen-antibody reaction. So the coloring agent which you will add in this immunohistochemistry is DAB. This is a commonly used coloring agent, that is a diaminobenzidine. Because of this coloring agent only, you can easily identify the antigen-antibody reaction, which will be giving you this brown color. So the brown color is because of this diaminobenzidine. Then there was another question. Which of the following is virilizing ovarian tumor? Yes, this virilizing ovarian tumor is a alhenoblastoma. So out of these options, the virilizing androgen producing ovarian tumor, virilizing masculinizing ovarian tumor is your alhenoblastoma. So these are the questions I could get up to now, the students. So if you want to discuss further questions, put it in the chat box, or else give me the message separately so that we can discuss in the further our sessions also. I heard there was a question so-called like most common cause of hyperparathyroidism, that is a parathyroid adenoma. Parathyroid adenoma is the most common cause of hypercalcemia. I also heard there was a question on immunofluorescence. They have given the image of the immunofluorescence and they asked what type of immunofluorescence, but I could not get the image properly or the options. But what the students told that it was like the indirect immunofluorescence, that principle was employed in that thing. That was another questions in pathology, like from the students vaguely remembered those things. But arachnoblastoma will be the most preferred option, because if arachnoblastoma is there, we have to choose only arachnoblastoma. I don't know whether that was a multiple option question or a single option. If it is a multiple option, we can choose that. But a single option, it is arachnoblastoma. So guys, the lesson to be taken from this INICET is, like as in every exam, high-yielding topics are the must to go before the exams. Yes. So you could see from this discussion, most of the questions are from the high-yielding topic and the repeat topic. The question, they may be slightly altered. The way they have modified the question is slightly different, but the topic is same and the concepts and the facts they are asking are the same. Hardly one or two questions may be a new topic, that is of course new for, if it is new for you, then it is new for everyone. So no need to panic or no need to worry. Be thorough. The lesson to be learned is be thorough with your high-yielding topic, repeat topics, thorough it, and your repeat question, that is the PYQs, or your game changers. We should attend all 100 out of 100 from the PYQ. Yes? Yeah. Hypercalcemia, it is a parathyroid adenoma. Parathyroid adenoma. Yes? Then HCG, actually HCG was the least common. HCG is usually elevated in choriocarcinoma rather than in your seminoma testis. HCG can be elevated, but it will be the least likely to be elevated. HCG first elevated, now you'll be thinking of choriocarcinoma. Yes? Any other question, if you are remembering, please put it to me separately or even in the chat box. We'll be discussing. Okay. Okay. So if there are no further queries, guys, thank you for giving me this live interactive session. And definitely you deserve a good relaxing sleep today. And tomorrow, all the best for your exam results. Okay. So wish you all to see in your central institutions, in good ranks, in your dream specialty, in your dream institutions soon. Wish you all the best, guys. Good luck.